Welcome to the Psych Experience.
Hello, everyone, and welcome to the Psych Experience. I'm Dr. Nardi. I have Pedro here with me, and today we're going to interview Dr. Mark Horowitz. He's a clinical research fellow in psychiatry at the National Health Service in England, an honorary clinical research fellow at University College London, and he's a training psychiatrist. He has completed a PhD from the Institute of Psychiatry, Psychology, and Neuroscience at King's College London in the neurobiology of depression and antidepressant action. He's the co-investigator on the RELEASE trial in Australia, evaluating the effects of gradual hyperbolic tapering of antidepressants. He's an associate editor of the journal Therapeutic Advances in Psychopharmacology, and is a guest editor for a collection of papers on discontinuing psychotropic medications. He co-authored the Royal College of Psychiatry guidance on stopping antidepressants, and his work informed the recent National Institute for Clinical Excellence, as we know, the NICE guidelines on safe discontinuation of psychiatric medications. Dr. Horowitz has written several influential papers about safe approaches to tapering psychiatric medications, including publications in the Lancet Psychiatry, JAMA Psychiatry, and Schizophrenia Bulletin. He has an interest in rational psychopharmacology and deprescribing psychiatric medication. He has experienced the difficulty of coming off psychiatric medications firsthand, which has informed much of his work. He has co-founded Ultra Health, which aims to set up a clinic to help people come off unnecessary antidepressants in Canada and the US, which is a common topic here in our podcast. And he does that by using gradual hyperbolic tapering combined with support and guidance delivered by clinicians through digital means. Mark, thank you very much for accepting our invitation.
Thanks so much for having me, Rod.
So I think, I know most of your work, not all of your work, but most of your work was focused on antidepressants. And now you have been, spreading it all over all psych medications when it comes to discontinuation. But I would like to really focus on antidepressants here. And I wanted you to talk to us about if there's any data that contradicts the usually accepted belief that antidepressants are actually antidepressants, if that is a misnomer, or if actually, antidepressants really improve mood in a general sense.
Sure. So I think there's a few things to say about antidepressants and how effective they are. So I think the first thing is to realize that even the data that is said to support them as antidepressants is itself very limited. So there have now been hundreds of studies done on antidepressants, not all of them published. The biggest analysis of antidepressants are these meta-analyses that have looked at hundreds of studies. And there have been about 5 or 6 meta-analyses, and they all find the same effect. And that effect is the difference between antidepressants and placebo or sugar pills is about 1.8 points on the Hamilton Depression Scale. The Hamilton Depression Scale is a 52-point scale that measures different aspects of depression, from mood to sleep, to appetite, and sugar pills by themselves over about 6 to 8 weeks improve mood by, improve the scores on these Hamilton Depression Scale by about 8 points, and antidepressants improve it by about 9.8 points. So there's a difference of 1.8 points. The difference between antidepressant and placebo is about a quarter the size of placebo by itself. And most people agree that is a very small effect. There are 2 ways that people have generally used to work out, is this a clinically important effect? So it is statistically significantly different, and that is why people claim that antidepressants are better than placebo. But we've also got to ask, is it clinically important? Is this enough to have an effect on people's lives? So for example, we could show that a weight loss drug is more effective than placebo to a statistically significant degree. But if it only helps you lose 50 grams of weight, it's not a clinically important difference. So when it comes to depression, in general, people use a rule of thumb that a difference of 0.5 standard mean difference counts as clinically important. In England, we have a institute called NICE, that determines treatments for the country, and they use that cutoff of 3 points on the Hamilton Depression Scale between a treatment and placebo to be clinically important. Actually, there are empirical studies that have looked at this, and in these studies, they ask clinicians, do you think this patient is not improved at all, minimally improved, moderately improved, or greatly improved? And they use that to correlate change on the Hamilton Depression Score. And what they find is that for a clinician to note that a patient is minimally improved, the barest change requires a 6 to 7 point improvement on the Hamilton Depression Scale. So using that 6 or 7 points is a minimally important difference, then the effect of antidepressants compared to placebo doesn't meet a clinically important threshold. So it's statistically significant, but it's not clinically important. Then people say, well, that's the average effect. The average effect is 1.8. There's widespread agreement on that. But people hypothesize, well, there might be a group of people who respond more than the average. And there have been about 4 studies looking at them, looking at that possibility. Is there bigger differences for some people? One famous study found that looking at the baseline severity, so looking at mild, moderate, and severely depressed people, there is no difference in the effect of antidepressants. It's all about 2 points, that 2-point average difference, even for the severely depressed. It still doesn't get to that 3 points minimum clinically important difference, let alone that 6 to 7 point clinically important difference. A few other studies looked for heterogeneity. That is, are there differences in the response to antidepressants versus the response to placebo? Is there greater variation? And 3 out of 3 studies found there is not greater variation. The latest study to come out in the British Medical Journal just last month claimed to find that there was a subgroup of people that had a large response to antidepressants when given a much larger group that had a large response compared to placebo. But this was a real data dredging exercise where they couldn't identify who these people were, but using certain statistical post hoc analyses, they claimed that you could separate the data into a group of people that had a large response when given antidepressants. But that study, like all the studies I've mentioned, actually have significant limitations that mean even that 1.8 point difference is very unlikely to even be that large. And I'll just quickly talk about the 4 major problems with these studies, if I can. I've probably gone into the next question, actually. Number one, people debate on which are the biggest problems with these studies, but I think the biggest problem with these studies is they go for 6 to 8 weeks. So we know lots of drugs are effective at 6 to 8 weeks. For example, benzodiazepines are fairly effective at reducing anxiety scores at 6 to 8 weeks, as anyone who has taken benzodiazepines will be aware of. Opioids are very good at reducing pain at 6 to 8 weeks. I imagine there'd be quite a few drugs that you could take that would improve your levels of anxiety and mood at 6 to 8 weeks, including some recreational drugs. But what we know about benzodiazepines and opioids and other recreational drugs is that, number one, there are tolerance effects. So these effects wear off over time. We know for benzodiazepines, by 6 months, almost all of their advantages have disappeared into tolerance. Their anxiolysis properties, their ability to help you sleep has all disappeared because you become tolerant to the drug, and very similar for opioids. Antidepressants have not been studied nearly as well in the long term, but tolerance is an issue for antidepressants too. People say that's controversial. It's not at all, because antidepressants clearly cause withdrawal effects. Any drug that causes withdrawal effects causes tolerance. Tolerance and withdrawal are 2 sides of the same coin. The reason why you have withdrawal effects is because you become accustomed to a drug, which means your brain is adapting to the drug, and that means it has less effect. which is what tolerance is. And that's why when you stop it, your brain is used to that effect. And when it's gone, it misses it. And that missing is what causes withdrawal effects. So we know that even these small effects that antidepressants cause at 6 to 8 weeks will diminish over time, so that they will certainly get smaller and smaller. So if they're not clinically important at 8 weeks, they're going to be even less so after months and years. That's number one. Number two is there's a huge issue with unblinding in these studies. So doing a study with antidepressants is not the same as doing a study with a statin or a blood pressure medication, because people know they're on an antidepressant. So as someone who's used an antidepressant, I find it completely difficult to believe that anybody could be given an antidepressant and not realize they're on it. Not only does it cause adverse effects like nausea, headache, dry mouth, etc., but it causes also subtle changes to how you feel. The way it's very hard to put into words, but it has a drug effect. It's a psychoactive drug, and it makes things appear a little bit different, as if you're using some sort of recreational drug. It's sort of like the idea that these studies could be blinded, to me, is the same as saying if you give someone a glass or two of beer, that they wouldn't know that they've been given either water or beer. There's a subtle change that lets you know you're on a psychoactive drug. And unblinding, we know, has a very big effect on the outcomes of studies. So if you're unblinded and you know you're on an antidepressant, it will trigger expectation effects. You will expect to get better.
There was a study, I think, in the 80s comparing antidepressants to active placebo. And then they couldn't find any difference between them both, because the active placebo would cause similar side effects like dry mouth and things like that. And I think, I can't remember the author right now. But that impact that you mentioned also is seen in clinical practice by far. People, when especially now, there's interventional psychiatry taking place, and the insurance requirements, they pretty much require us, which is something we already did in clinic, which is to say, okay, what stuff were you exposed already to, and what happened when you took the medication or that medication, and what we have for that population, which is clearly a big confounder for generalized or for anxiety traits or some personality traits, is either awful side effects or an initial report of improvement or a change, because I took an antidepressant for a while, and so did my mother. And what we noticed within the first month of exposure is that both of us developed essential tremors, and it has been with us since then. And I think I found that in maybe one paper, but you don't find that usually in your usual report of side effects. But it was funny to see happening to me. And when she started the same very antidepressant I took during medical school, and I guess ended my aspirations as a surgeon. But anyways, she also developed, and is still, she doesn't take anymore. I don't take anymore for many years, and she still has the tremors, and I still shake like a leaf. But what we see is really a numbing effect, to a degree of actually having, if I can recall properly, and I hear that a lot from patients, is a lack for regards for consequences, and you get a little bit indifferent to things, and it may translate into a little bit more impulsivity and being more snappy with things, or as if which is quite different from claiming it's an antidepressant if it's just a numbing effect, which kind of brings me to a similar topic, and then we can continue on what your thought doesn't prevent us, but do you think there's a use for that in clinical practice? Because one thing that I talk a lot about in my mentorship is we don't have a clear framework to combine psychotherapy. And I don't know if you know, I was a psychologist for many years before I went to medical school, for a few years, I would say. But we don't have a good framework to combine the use of available resources from psychiatry with goals of psychotherapy, right? And one example that I use is, let's assume antidepressants really made you happy. That's one of the would you prescribe that to someone living an unlivable life, a miserable life? Is that even ethical, right? So I struggle with figuring, and one of the things is because psychiatry does not have absolute values. If you look to DSM, the value that you extract from DSM is please do not feel anything, while psychology and psychology schools of thought will have things like, sort of, go on an adventure, make the most of your life, self-awareness and things like that. Even live your full potential, if you will. I couldn't find yet a proper framework to use medications to help people go through tough patches and then remove it. And, but again, considering that SSRIs could have this change that you just described, which is very hard to explain, very hard to put into words, would you see a use for that at all?
So I think you make a good point. I do agree with you that there's a very good chance that the way that antidepressants work are as being numbing chemicals. I mean, we know that people who are on these medications, about 50 to 70% of them will say that they feel emotional numbing. That is possibly related to their physically numbing effects. The sexual side effects, the reduced sensation of genital tissue may be related. In fact, I've been writing about these drugs, how to make up small doses, and that involves crushing them sometimes and mixing them in water. And one of the things that the pharmacology textbook keep on saying is these drugs produce a mild anesthetic effect in the mouth if you crush them and swallow them. That makes me think that these drugs do have a known mild anesthetic effect, and that's they're used for pain, for example. So might they be doing that in general for physical and emotional sensations? And I guess that would on these depression scales make people look like they're better because their depression scores are better. And so that might be one way it works. Definitely something that I've experienced firsthand being on antidepressants. So I think that's a very plausible explanation. In fact, I think that's got to be the go-to explanation because it's proven to exist. It clearly would improve depression scores. All the other explanations for how antidepressants work, neurogenesis, inflammation, stress hormones, neurotransmitters, none of that has been proven in humans. So I think the default explanation really has to be this numbing one. That's the most obvious proven explanation. Other ones would have to displace that to show that they're really doing something. And then the question you've asked me is, could that be useful? Now, I'm in two minds about that. The line, is that medication can settle you down enough so you can engage in therapy. Maybe that is true, but I'm not entirely sure. The short-term studies do show that if you combine, a manualized therapy like CBT with antidepressants, you get more of an effect than just antidepressants by themselves or the therapy by themselves. But again, that's not long-term treatment. So there might be a slight boost from being numbed and a slight advantage from a manualized therapy. But of course, we're talking about people's lives, and people are not in 6-week studies. They're taking these things for months or years. We've done an analysis we haven't published yet, which shows actually that people who are on antidepressants have worse outcomes in therapy than people who are not on antidepressants. And we speculate that possibly being on antidepressants means you're not thinking quite as clearly because there's a clear cognitive impairment that comes from being on antidepressants. It's on the patient information leaflets in some of the drugs that it causes concentration impairments. I think that might make it harder to do therapy. Number two, if your emotions are numbed, it's harder to access negative emotions. I think a lot of therapy involves exposure to negative affect that you can then reprocess or re-understand. If you can't access those emotions, it's harder to deal with them. So I'm not sure. I can see the rationale of if you're in complete strife, that numbing for a few weeks might give you a reprieve. And so I can see that there's a rationale for giving people short-term antidepressants. But my concerns about that are the short-term very quickly leads to the medium and the long-term, because once you're on these drugs for 4 to 6 weeks, you develop physical dependence. And that means you're likely to experience withdrawal effects, which makes it harder to stop. If someone experiences a beneficial effect, they may want to keep taking the medication, even though we would suspect that this effect will get less and less. So, not to mention all these adverse effects that people have, sexual side effects. And we're now learning that some of these effects may be permanent or at least long lasting. Generally the adverse effects like sexual problems and emotional numbing go away when you stop the medication. But we're also learning that sometimes it doesn't go away. And generally these problems are more pertinent if you're on these drugs long term. But there are cases of people who are on the drugs short term who have long-term problems. And so it's very difficult to weigh up this advantage from a numbing effect that might give someone a break for a few weeks versus the risks that you're taking on in introducing a chemical into someone's brain and body and not really knowing what the long-term effects will be. So I'm really undecided about that.
Yeah. One thought I have is that one of the things as a psychotherapist and as a psychotherapy patient or analysis, I would say, is that one of the things that motivates change, and I don't want to sound overly Skinnerian here after saying that I do analysis, but one of the things that motivates change is really the misery that people are feeling. And I wonder if that will be, just for the sake of our conversation, I wonder if that will be a factor, limiting effects of psychotherapy according to the findings of that. And then please let me know when you guys publish that, because one of the things that motivates people to do what needs to be done, and that's pretty much what psychotherapy, one of the psychotherapy's goals, I would say, which is to find the truth and change your environment or your circumstances, and that is awfully difficult. It's much easier to stay in misery, especially human beings. We can adapt to things, like to unthinkable things, and by suppressing the sense of misery, you decide then to stay in an unbearable marriage, an unbearable job, or overall unbearable circumstances, and not even try the options that are out there in a fairly unlimited reality. That's where we are. But that is a very interesting thought, a very interesting paper that you're mentioning. How did you guys go about, and what is the if I may ask on this paper, what is the time range where your guys are finding this data to be the case, and what numbers you guys found in terms of patients that you're following?
I just reflect on what you said about adversity leading to pain, leading to change, and if you intervene in that process, you might take away the ability for people to change. I think that does make a lot of sense. I mean, the problem with putting forward such an argument is, people accuse you of being cold-hearted, and too tough because everyone else is rushing in to give help, and you're saying no, it's good to experience the pain, and people criticize me and colleagues for saying it's too unsympathetic. From me personally, as a patient, I absolutely agree with what you've said. I went on antidepressants because I didn't like the course I was doing. I think the antidepressants made me a little bit, more permissive towards it. It stopped me making a change. The change was very delayed, and that had big consequences on my life. So, although me, the 21-year-old distressed person looking for an answer, was very happy to be given one, looking back with the, maturity of age, I would rather have gone through the experience myself and made the right change. So I think that's got a lot of value. What you're saying, I think of an analogy to pain, physical pain. People that don't have physical pain will keep on touching a hot element on the stove, or lose a feedback loop, which is something that is life-preserving. In fact, people that lack sensation in their skin often die early because they don't realize what's happening to damage their bodies. And I think much the same could be said of antidepressants that cause this mild numbing. I think people do lose sensitivity to relationships and situations that probably causes them to make poorer decisions in the long term. I think there's lots of examples of that. On the study that we've done, so what we did is we basically wanted to do something that was naturalistic. So rather than getting people in 6-week studies where you give them antidepressants and cognitive behavioral therapy, we wanted to look at what's happening in people's actual lives. And so what we did was looked at there's a psychology service that is paid for by the government in England that is very large, called the IAPT service, the Improved Access to Psychological Therapy. And people will come in either on antidepressants or not on antidepressants and be given 6 or 12 weeks of therapy. And most people are on the drugs long-term, months or years. And so it's a more naturalistic way of seeing what happens. And, you know, it's a very well-run service, so they take all sorts of measurements at the beginning and at the end. And basically what we saw was that people who were not on antidepressants were about 30% more likely to respond, that is to improve in their mood and anxiety at the end of their course of treatment than if they were on antidepressants. Then when we controlled for, you know, were these people more depressed on antidepressants versus not on antidepressants, which was a little bit true, we modified that, and still people who were not on antidepressants still had about a 10% improved likelihood of improving compared to people who are on antidepressants. It wasn't a big effect, but what it does certainly say is the opposite is definitely not true. You know, it didn't show that people who are on antidepressants had a bigger effect when they were given therapy. So either there is no effect or a slight worsening. So that makes me skeptical about saying that, you know, a combination works better than just therapy alone. In fact, I think there are now longer term studies, systematic reviews showing basically that psychology, that therapy versus combination treatment has the same outcomes at a year or longer. And that combination therapy plus medication has better outcomes than medication. So to me, putting into you know, the adverse effects of drugs, it seems pretty clear in the long term that it's better to have therapy by itself than to have the combination together.
Now, have you guys found any difference between agents? Consider, because we're calling them all antidepressants, but at the end of the day, some of them are very distinct chemicals. If we were to compare, for example, bupropion with SSRIs. SNRIs, yeah, but you know, have you found any difference or the research that you have been involved in or the one that you have knowledge of didn't look into that detail?
Yes. So in the study I'm talking about, which actually I should have mentioned is very large, I think we had 40,000 participants in it. So it was a big trial, but an observational trial with all the limitations that entails. We do have the data on particular drugs. Mostly people are on SSRIs because bupropion is not used very often in England. So I'm not sure if there was differences between drugs. I'd have to go check the data.
Very cool. And another thought about it is that we're talking about how to match medications, and because I asked, I have this mentoring program, and when I asked the students, they're all, you know, mostly practicing nurse practitioners, and I asked them the question: if antidepressants really work and make you happy, would it be ethical to prescribe to someone who is living an unlivable life and, you know, make you happy in an unbearable circumstance? And it's a funny thing that the answers diverge. And I went as far as trying to figure what it is that makes a difference in that regard, which could be a way to look from a philosophical perspective, maybe into the question: do they have a use, and how we use this is worth to patch people here and there. And what I notice is that the people that say, yeah, it's an ethical thing to do, they use personal examples of tough times in their lives where they could not run away, like being the sole caregiver of a dementing parent, or, you know, because what changes can you operate, or being divorced and having to raise 3 kids by yourself because your ex just disappeared, you know, and everything being very tough, versus the folks that say it doesn't sound ethical. They use as personal examples things where they would say, well, I should have made a change when I could. And so it's a very interesting thing. Now, on the more or less the same line, about, you know, our listeners, would you say, what would you say to our listeners that, you know, from a clinical perspective, have had successful stories with antidepressants? You know, is that all biased observation, is it possible that they do make a dent in a small group of people and we're just bad at identifying them?
I mean, I guess my thoughts on that are, I mean, in answer to your previous point, you know, of course, the idea that we could create happiness, you know, you're using it as a hypothetical, but of course it's completely implausible. You know, there's, I mean, there are drugs, you know, there are drugs that create euphoria, but we know that those drugs, you know, are short term. I mean, if you give someone cocaine, you know, they feel euphoric. You know, but we know that there's no, I mean, there's no such thing as a free lunch in psychopharmacology. You know, if a drug makes you feel great, you're going to feel terrible the next morning, or it's going to wear off, or it's causing some kind of brain damage, like a lot of recreational drugs do. So I think, you know, that there is no such drug that creates happiness. There are drugs that might cause numbness. There are drugs that might cause a temporary euphoria. And I don't think any of those drugs are likely to play out well in the long term. You know, as you can see from recreational drug users are not happy, you know, well-functioning people. And I think that's a slight message for what these other drugs might be doing. So could it all be a result of biased observation? Look, I mean, I think one, the placebo effect is very strong. You know, sometimes people feel criticized if they're being told that their response is because of placebo effect, like they were tricked in some way. But look, our minds are very powerful things. You know, there are studies that show that if you give someone an antidepressant and you tell them it's an antidepressant versus half of the group you tell it's not an antidepressant, even though it is, the people who are told they were given an antidepressant will have twice the response in depression scores as those that were lied to and told it wasn't an antidepressant. So believing it's an antidepressant has a very big effect on the response. In fact, there are studies where they've gone back and asked, did you think you were given an antidepressant or placebo in a placebo-controlled trial? And the major thing that determines the response is what they guess. If they guess antidepressant, they have a big effect. If they guess placebo, they had a small effect, no matter which drug they were given. So we clearly, I mean, there's a lot of, you know, depression is not like blood pressure. It's a very subjective state. It goes up and down. You know, whether we feel hopeful or not has a big effect on it. And so, you know, the placebo effect is very large in antidepressant trials and in things to do with mood. So I think it is plausible. Then number two, you might have this numbing effect, and the numbing effect can make people, you know, feel they can breathe again. Maybe they feel a reprieve, which can give them a break. And I think the other thing is, this happened to me, I think, you're a bit distracted because now you've got side effects. I remember I was a bit nauseous. I felt a bit funny. It was sort of a distraction from the issues that were, you know, concerning me. So in some ways, the side effects might be in some odd way have a therapeutic benefit, you know, at least in the short term. Because now you're talking about, you're thinking, is this because of the drug? Should I change my drug? Is it working? You sort of got a new set of thoughts. It may not be particularly helpful in the long term, but might give you a distraction in the short term. And then, and I know there are people that I respect that disagree with me, but I do think in some people, antidepressants produce a mild euphoria. You know, I've seen it happen, except in every single one of those cases, it seems to wear off. So I think there are ways that antidepressants could make people feel better. I think they're all short-term effects. And I think those things could all explain why people feel better rather than there being some genuine effect on the underlying cause of depression. And so I think there are lots of ways that could happen. And can I just go back to your point about people who are in situations that they cannot change, who are therefore more inclined to take medication or to give it? I mean, so I completely understand that, and I kind of feel I'm speaking from a position of privilege. My major problem was I didn't like my university course. I could have changed it. I get it. That's not the most intractable problem in the world. It's not the same as being in poverty and having 3 children to look after, you know, being divorced. I understand that. Intractable situation makes it much more attractive for you to want to use a drug solution. I'll say a couple of things. I'd say one, practically, taking a drug like an antidepressant that might make you a bit numbed, a little bit less sharp, might make life harder, actually. If you've got to look after 3 children and you've got to keep working, for example, you might think, well, numbing might help you get through, but if it creates tiredness and difficulty concentrating, it might make your job actually harder in the long term. And the second thing is to step back. And I know I could be accused of being idealistic, but I think if we've got to name what the problem is in order to solve it. If the problem is there's a lack of benefits for a single mother with 3 children, or there's a lack of access for a man to his children, or whatever the social problem is, then the solution has to be legal, political, and social. We can't pretend that the solution is chemical, even if it's a very intractable problem. So I think we shouldn't pretend that the problem is a neurochemical one, when it's clearly it's one of the way that our societies are organized. Unless we say that, even if it's very difficult. I know the situation in America is never simple, or in any other country, but we've got to name what the problem is in order to even consider the possibility of a solution. And so I would kind of keep that as much front and center as possible.
You are absolutely right. And I think considering, and recently a colleague, a psychiatrist that listens to my podcast, good friend of mine, and he gives me very good tips and feedback. He said, he referred to me on a text message as an activist. And I said, no, I'm a strategist. I'm trying to make doable changes because American population was led to believe there is polarization in our political field, and there's none. Everybody's following. I mean, this is a country where lobby is a legal profession as opposed to be corruption, as we call the rest of the world. But nevertheless, I love it. So that leads usually to my kind of thought process, where I get to find the doable things first. And yes, to a point, for example, where psychosocial stressors on a risk assessment will be considered a fixed risk factor. We're not trained to address that, and too bad, life is tough kind of thing. But did you see or do you have any knowledge on research of what is a safe time to be exposed to that medication to antidepressants without drastic withdrawal side effects, which would be our next topic?
Right. Your sound just went a bit out for me, but I'll continue on, hoping it's just my connection rather than your connection. I could hear what you said. And the question is, how long does it take someone to adapt to a drug so that they're at risk of withdrawal? The official literature says 4 to 6 weeks. After 4 to 6 weeks, you've started to adapt so that withdrawal symptoms are observed. So, for example, in a lot of the industry trials, people are exposed to antidepressants for 6 to 8 weeks. There's often a 2-week washout at the end, and they observe withdrawal symptoms. And in a lot of those studies, more than 30% of people will have withdrawal effects. In fact, after 8 weeks on venlafaxine, already 3% of people are having extremely severe withdrawal reactions, and about 50% or more are having moderately severe reactions after just 8 weeks. So there are lots of people who think 4 to 6 weeks is conservative. And I'll make an analogy to benzodiazepines. Officially, it says it takes 2 to 4 weeks to become tolerant, dependent on benzodiazepines, and to put you up for withdrawal. The FDA came out in 2020 and said, actually, it's days for some people. So there are reports of people being on these drugs only for a few days and having withdrawal effects. And there's enough such reports that it made the FDA put that as its official statement. So if you go now to the FDA label for any benzodiazepine in the country, it will say you can experience tolerance, dependence, and withdrawal after just a few days of use. So I don't know the studies on antidepressants, but to me, it's unlikely to be that different. So I would say in a few days or weeks, you can certainly build up a tolerance and physical dependence on antidepressants, which makes it very hard to say what duration of treatment is safe.
Fair, very fair. Yeah, and the question I ask is because we made an analogy with recreational substances, and there's a sea of people out there that smoke a cigar once every 2 weeks, and they have a great time. Someone who smokes pot once a week, or someone who takes, talking about as needed use benzodiazepine a couple of times or 3 times per month. And from a clinical perspective and empirical, if you will, the impression you have is that the high or the benefits, if we put them in the same basket, are they persist. You know, you don't have that quick, I started 0.5 milligrams of lorazepam a month ago. It was the best thing ever happened in my life. The benefit is gone. Can increase to 1 milligram now, and that's how, you know, yesterday. I'm not going to give specific details, but I frequently see in my clinic, you know, practicing the genitorial psychiatry, people taking 6 or 7 milligrams of Xanax or lorazepam, absolutely miserable and very attached to the medication, and you know, even if you suggest a taper of 0.25 milligrams of that whole dose, generates a whole emotional response. And but again, back to the withdrawal of antidepressants. What do they look like, and do they involve changes in mood that would lead people to believe, oh, you see, this medication was actually treating my depression is back, and confuse the withdrawal, just like happens with benzos when the withdrawals involve anxiety, and people think of, even though anxiety is a trait by all means, you know, in comparing people, you know, it's a laid back person, unless going through some tough times, is going to be laid back all their lives, and more anxious people have anxiety as a trait since childhood, but yet our diagnostics are thought as nouns as opposed to verbs, right? They don't see things as going through something. They see them as entities and you know, like actually diseases, as opposed to syndrome, which is just a collection of signs and symptoms. Does that happen with antidepressants? I mean, people going off antidepressants as a virtue of the withdrawal would experience slow mood and anxiety and say, oh, you see, this thing was here all the time, the medication was helping me.
So in answer to the question, are withdrawal effects from antidepressants mistaken as a relapse of the underlying condition? The answer is a very loud and very resounding and very common yes. The simplest proof for that is there are now hundreds of thousands of people who are on Facebook groups and peer support websites getting advice on how to come off their antidepressants. And they are all there for the same reason. And that reason is their doctor told them, their GP or psychiatrist told them how to come off their drugs. They experienced withdrawal effects. The doctor said, it's not withdrawal, it's relapse. And you need to go back on your medication, perhaps you need it lifelong. And every one of those people thought, that doesn't make any sense. These symptoms are different. I've got extra symptoms. This is not the same as relapse. I don't think my doctor, you know, knows what he's talking about, and ended up on these Facebook sites. So there are hundreds of thousands of people that have had exactly what you've just said as a theoretical concern, withdrawal effects being misdiagnosed as relapse or recurrence. And I'll explain how it happens. So yes, withdrawal effects from antidepressants have now been well characterized, and they involve lots of different symptoms. There are physical symptoms, headache, dizziness, people get electric zaps in their head sometimes from coming off. And that's because serotonin affects so many different organ systems and endocrine systems and the neurological system. And that's why you get gut symptoms and other neurological symptoms. And of course, antidepressants affect the brain, and you get emotional symptoms. And the emotional symptoms that are most common are depressed mood, anxiety, panic attacks, suicidal thoughts. People cry uncontrollably, people get angry, people become very fearful, and sometimes people experience mania, and very rarely people experience psychotic symptoms. And the reason why that is likely to be is because antidepressants affect serotonin and noradrenaline and dopamine and all sorts of different chemical pathways. Your brain adapts to that. When the drug is removed, there's another process of readaptation of the drug being gone. And that process involves all sorts of transmitter systems in the brain. And so things go awry. And the symptoms of the brain going awry are emotional symptoms. We know that these symptoms are withdrawal effects and not just a return of people's underlying condition, because they occur in people with no underlying condition. So in studies that look at people, no underlying mental health condition, in studies of people who are put on antidepressants for pain, for the menopause, people have these emotional withdrawal symptoms. In other words, you can be fairly certain that these emotional withdrawal symptoms are because of the withdrawal process itself, because there is no underlying condition to recur. The other way we know that these emotional symptoms are withdrawal symptoms is people, even with mental health conditions, will report new symptoms that they never had in their original condition. So, for example, a case that I've seen, and is very representative, is someone went on the medication because their father died and they were low in mood and they slept all the time. Now, 3 years later, they've come off the drug too quickly and they're complaining of anxiety, panic attacks, not being able to sleep. So you have, those are all emotional symptoms, panic, anxiety, insomnia, but they're different, in some cases the complete opposite of sleeping too much and low mood. So if you've got the choice between, is this a new onset panic disorder that just coincidentally happens to coincide with the moment they stopped a drug versus well-recognized withdrawal symptoms from coming off the drug, it's very, the probability should be these are withdrawal symptoms. They occur a few days after stopping the drug. It's much more likely to be emotional withdrawal symptoms rather than coincidental onset of a new mental health condition. And there are various other ways to tell the difference between withdrawal symptoms and relapse. Not always simple, but there are a few guides. Number one is the timing. So if something happens a few days after stopping a drug, it's much more likely to be withdrawal effects, because relapse shouldn't happen for weeks or months afterwards. It should be determined by whatever the periodicity of people's mood condition is. It shouldn't coincidentally happen just a few days after stopping medication. The one confusing thing that I've seen a few times, read about in the literature, is this delayed onset of withdrawal effects. I've sort of heard it now too many times to ignore. People will have minor withdrawal effects, maybe for a few days or weeks afterwards, but at 3 months off their medication, they get terrible withdrawal effects, and very clear withdrawal effects, electric shocks, panic attacks that they never had before, trouble sleeping. I don't understand the physiology of that. It would make sense. The drug leaves in a few days. The symptoms should happen a few days after stopping. But again and again, I've heard this story of delayed withdrawal effects, which makes things confusing, I think, for clinicians. Some people have suggested that maybe the drug stays longer centrally than it does peripherally. And there is a little bit of evidence that it stays attached to serotonin transporter receptors in the brain longer than it's present in the blood. But I think it's only a few days. I'm not sure that explains it, but there is delayed effects. The other thing is, when you get physical symptoms and emotional symptoms that come together, yes, you have low mood, yes, you feel anxious, but you're also dizzy and have electric shocks. It's much more likely it's a withdrawal syndrome with multiple symptoms than two coexisting withdrawal and relapse. This is Occam's razor. I learned this in medical school. One condition is likely to be responsible for 4 symptoms than having 4 conditions responsible for 4 symptoms. So I think if someone comes in, they say, I feel miserable, I can't sleep. The next question should be, are you also dizzy? Do you have a headache? Is there anything else that can help distinguish it from your underlying condition? Whereas I think a lot of doctors stop their diagnostic work, then they hear, I feel terrible, they think relapse. But I think we've got to ask about other symptoms. The third thing, which is more helpful in retrospect, is when you restart the drug, withdrawal symptoms often go away in a couple of days. People feel half better after a couple of doses, whereas relapse should take longer to improve. So those are the sort of things that can help you distinguish. But I think a lot of doctors at the moment are making that mistake and seeing relapse. In fact, I think, when I lecture to doctors, and someone says, I've never seen withdrawal before. I know that they must be missing withdrawal and seeing relapse. And the reason I know that is studies now, meta-analyses of randomized controlled trials show that the rate of withdrawal symptoms from antidepressants is about 50%. About half of patients will have it. The data on severity is not nearly as strong because it's from surveys. The surveys suggest it may be up to half of people that have withdrawal effects have severe withdrawal effects. So maybe it's 1 in 4 people. That's a lot of people having withdrawal effects. So if doctors aren't seeing a lot of their patients having withdrawal effects, I think they're missing it. On the other hand, the rate of relapse is very uncertain. we really don't know how many people are actually relapsing, because the meta-analyses that we use to tell us that show that about 40% of people, maybe 50%, relapse when they stop their antidepressant. But in all of those studies, they don't take out the withdrawal effects. So if we know that half of people are having withdrawal effects, and we think, ignoring withdrawal effects, that half are relapsing, then really the true rate of relapse is way less than 50%. In fact, there are people who have done calculations saying the rate of relapse may be almost zero, because if all of that is withdrawal effects, then we are vastly overestimating relapse effects. In my experience, withdrawal is the horse and relapse is the zebra. It's very common to have withdrawal effects. I'm not sure how common it is to have relapse. I'm sure it does exist. Of course, people who maybe were positively affected by the medications. Maybe it was numbing. Maybe it had a mild euphoria effect. Maybe they are uncovered. But it's very hard to know what that percentage is if you take away the proportion that's withdrawal. So, every time I speak to doctors, I urge them, please have a high index of suspicion for withdrawal. It's very common. It's probably pretty common for it to be severe. You've got to ask these other questions, look for symptoms other than anxiety and depression, compare it to the original condition. The best clinicians will write down, what were your 3 symptoms when you went on the medication? What are they now? If they're not the same, you've got to be thinking this could be withdrawal. And the other test is put someone back on the medication. Now try taking them off more slowly, because if going off more slowly reduces the effects, it's clearly withdrawal. So I think there's a lot, doctors could do a lot better by their patients by being more aware of withdrawal and how to avoid it.
That makes a lot of sense. And overall, I have a feeling that, still talking as a strategist, as I mentioned, that we just have to figure better when taking risks is worth it. We are also not very good with patient selection, but what happens with people reporting symptoms compatible with, the diagnostic criteria of depression is that some people report them through their lives and some people have them in waves, and we're just throwing them all in the same basket. A lot of lay people that I talk to with the Instagram page or Facebook will say, I have had these problems all my life, and they're very resistant to the idea of understanding major depressive as a verb, as I mentioned, as an analogy. That all makes a lot of sense. So we're really talking about a few days for some cases when it comes to developing tolerance to medications, and then the very slow taper, which is the hyperbolic taper that you work on, and you have the ultra clinic and everything else going on. You mentioned in New York for the next year. That's very interesting. Mark, listen, amazing talking to you. I hope you'd be available for a future chats. I don't know if you have any other comments to make. Please feel free. This is our chat.
I'll just say one thing, at the risk of editorializing here. You talked about people that are miserable a lot of the time. And I guess that there's this sort of conflict between wanting to do something and wanting to be helpful, which is very inside of us as doctors. I mean, and as humans, as mammals, we want to help, but I think, and I sort of put my hand up as I am one of these slightly miserable people. That's just, I don't know, being brought up in a neurotic Jewish household or whatever it is. But so speaking as a patient, I wish that earlier on I'd been told, yes, you're a miserable young man. Yes, it probably relates to all sorts of complex dynamics in your family and your life. And there's no magic bullet to solve it. The only solution is, the choices you make in your life and what you do. I would have been disappointed, at 21 when I wanted a life jacket. Someone said to me, there's nothing here, the store is empty for chemicals. I would have been a bit pissed off. I probably would have been angry at the doctor and said, I know there is, it's on the TV, it's people around me. But I think 6 months, a year later, I would have thought, I'm very glad that person told me that, because they didn't waste my time. Whereas they didn't say that to me. They did give me the apparent magic bullet, and they wasted a lot of my time. I spent years trying different medications, thinking through a biomedical lens. I had that horrible thought of, if I can find the right combination of medication, I'll get on with my life. That kind of the most disempowering thought you could possibly have as a human being. It led to, for me, I won't go into it, but it gave me medical problems. It gave me all sorts of adverse effects that actually really impacted my life for more than a decade. So if the person had given me a short, sharp slap across the face and said, there is nothing here, that would have changed the course of my life. And I do that to patients now. I say to them, I know you're miserable. I know things are tough. And I'd love to have a brilliant solution that I could just give you. You take it in the morning, it would be gone. But we just don't have anything like that. And most of them don't love hearing it. Some of them have said, I appreciate being told that, because they're rational as well. It is a fanciful idea that it would be a chemical that would solve all sorts of life problems. So I think that in the long term, we can do less harm and give more benefit to our patients by telling them hard truths, even though it might not make us the most popular person in our clinic. And that's what I would say.
Oh, very good. And you went through a lot of problems with withdrawals from antidepressants. You can talk that from both sides of this. I don't want to use the word trenches, but hey. So again, man, thank you for your thoughts. I would really, again, I'm going to repeat, I hope you'll be available for another chat in the future. And, it was a pleasure to have you here.
Pleasure to be here, Rod. Lovely to meet you. Lovely to talk to you. Happy to do it again. Cheers.
Amazing. Hang in there.
This podcast was offered by anypmi.org.